me about Craig.
Okay, so Craig is a 16-year-old male basketball player who landed on his opponent's foot with his right foot during a basketball practice. This occurred 1 hour ago. He complained of a pop on his right ankle, and he reports no previous medical history to the involved extremity, and he's unclear of the exact mechanism. He had edema on the anterolateral aspect of his right ankle immediately post-injury. He is able to partially weight bear with a 6 out of 10 on the pain scale. On examination, he had active range of motion of dorsiflexion to 5 degrees with a 6 out of 10 of pain, and plantar flexion to 20 degrees with 8 out of 10 for pain. Inversion is limited with 6 out of 10 on pain, and eversion is also limited with 6 out of 10 for pain. He reports point tenderness on the anterior margin of his lateral malleolus and anterior talofibular ligament. He is negative for point tenderness over the CFL, medial malleolus, or deltoid ligament, and he's positive for anterior drawer laxity and pain, positive for the compression test, and negative inversion talar tilt for laxity with a 2 out of 10 for pain. And he also had a negative posterior drawer. My differential at this time would be a lateral ankle sprain, an avulsion fibular fracture, and eversion ankle sprain. My reasoning for the lateral ankle sprain was based on him feeling a pop, indicating ligament involvement. Laxity and pain with the anterior drawer indicates ATFL injury. The negative talar tilt rules out CFL injury, and the negative posterior drawer rules out PTFL injury. My clinical experience, I've observed pain with dorsiflexion with ATFL injuries before, and he's point tender on the lateral malleolus, and him being 16 years old would indicate a need for an X-ray to rule out a fracture. My reasoning for the avulsion fracture would be because of his unknown mechanism of injury, but it should raise concern for a fracture in a 16-year-old male basketball player. The point tenderness on the anterior lateral malleolus, the pain with the anterior drawer test suggests a possible fracture. However, auto ankle rules indicate that fracture is only indicated if the lateral malleolar point tenderness is on the posterior border of the tip, and if the patient cannot weight bear for 4 steps immediately after injury or during evaluation. In this case, the patient is partial weight bearing and only has point tenderness on the anterior border of the lateral malleolus. My reasoning for an eversion ankle sprain was because also the unknown mechanism of injury. However, eversion sprains are rare, even with what is known about the mechanism of injury, and special testing and palpation clearly ruled it out. Is there anything else you would consider in your differential?
Well, did you think about a syndesmosis ankle sprain?
No, I forgot about that.
Well, why would you want to think about that in your differential?
It is an ankle sprain, and because of the unknown mechanism, it should be ruled out. I did perform a compression test, which also can be used to diagnose high ankle sprains, so I should consider that as well as pain with active dorsiflexion. However, they were not tender to palpate over the anterior tib-fib ligament.
Do you know the special test associated with syndesmosis ankle sprain?
No, I forgot.
It's the Kleiger's or the external rotation test?
Oh, that's the one where you dorsiflex the foot and externally rotate.
Exactly. We're going to definitely want to do that with your patient to help rule out the syndesmosis ankle sprain. But why don't we go ahead and talk about the plan of action right now?
Okay. Based on these findings, I am confident that it is a lateral ankle sprain. With respect to the treatment plan, we should continue to rice, and if he is unable to ambulate correctly, I'm going to put him on crutches for at least 24 hours. I'm going to ice him rather than whirlpool because I want to use elevation to help decrease the swelling, and I'm going to wrap the patient with a compressive wrap and a horseshoe pad to also help decrease swelling. And for range of motion exercises, I will have him do ankle pumps and ABCs. As far as a case to read up on, I was planning on reading a sensitivity specificity of the Kleiger's test versus the compression test in the diagnosis of high ankle sprains.
Sounds like a good idea. Well, you did a wonderful job. I think we should go talk to Craig now.
Okay.